Hi friends, so in this section of video, we'll be covering some key points related to PCOS. So the first thing is, while we keep all the list of differential diagnosis, when we see a patient with hyperandrogenic clinical or biochemical features, it is very important to rule out something which is the worst possibility, which is the androgen secreting tumor. The best way to do this is do the total testosterone. If that is uh, from 2 to 5 nanomoles per liter, then it corresponds to the PCO. And if it is more than 5 nanomoles per liter, then it could be an androgen secreting tumor. Usually the lab takes a very little time to do the total testosterone because they use the immunoassays, and they are more sensitive for the men's range of testosterone. So if the report is not convincing but you still have a high index of suspicion, then you can go ahead and do the mass spectrometry to test the total testosterone to make sure that you do not miss a diagnosis like androgen secreting tumor for a woman who comes with the hyperandrogenic features to you. The second point that I want to share is that if you have a transvaginal probe of the ultrasound which is of 8 hertz or higher, then you're good to go. It would be a fantastic scan to diagnose PCO. But if not, if this probe is not available, then the next best way to make sure that you're not missing the PCO diagnosis is to do the 2-hour OGTT, oral glucose tolerance test. The next point is, this has been missed by a few people, but this is a very important feature, which is the stromal abundance. Professor Robert Legro, who I believe has done the best work in PCO, and also a wonderful doctor that we have, Dr. Nick Rain-Fanning. So their studies have proved that the stromal abundance is a very key feature to diagnose the PCO. The peak systolic velocity in the Doppler of the ovarian stroma is higher in the patients with androgenic clinical hyperandrogenemia, and they are usually lower typically in the obese patients. If the PSV is high, it should create a doubt of the likelihood of prediction for that this woman would develop OHSS in the fertility treatment. To predict the ovarian hyperstimulation, stromal abundance with high PSV is a very good point. So we have a ratio of mean stromal area divided by the mean ovarian volume. If this is more than 0.34 according to one paper and 0.32 according to another paper, then this is nearly 100% specific for the diagnosis of PCO. The criteria of 10 cc of volume of ovary misses the weaker phenotype of those women who still are at high risk of these 4 things, which are tendency to develop hyperstimulation, miscarriage, recurrent implantation failure, and hyperinsulinemia. So this weaker phenotype of PCO is at risk of these, but this woman will not fit into the criteria of 10 cc volume PCO because her ovaries will be small, and but however she's still at risk. So this criteria will miss that section of women. I want to highlight this point that PCO is not a cause, but it is the result of chronic or even short-term anovulation. So when there is anovulation, plus under the effect of high LH, there's a conversion of granulosa cells to theca cells, and that builds up the stromal abundance, and that appears as first as patches of hyperechogenicity and then general hyperechogenicity. When we see the ultrasound, it is good to compare it with the ecotexture of the myometrium to judge. Another point is that till the age of 8 years after menarche, so around 22-23 years of age, till that age, all three parameters of hyperandrogenism, anovulation, and the ultrasound features, they should all be taken into account to diagnose the PCO. And also, Professor Robert Legro had earlier emphasized in his talks, which I fortunately happened to attend, where he stressed that it is important that we decrease the threshold of PCO with advancing age. Okay, the next thing is that it is very common for doctors to tell patients to go lose a lot of kgs of weight, and it is the hardest task to do. It is not an easy thing. So the direction of the curve is more important than the absolute weight loss. So even the 5% of weight loss will have majority of the women's ovulating, because the direction of the graph is indicative of the biochemistry rather than the absolute number of kgs lost. Another point that I want to highlight is that people have this tendency to very often prescribe cyprotron acetate for the younger people. It's very important that we keep into two things in mind. The first is a very high chance of developing venous thromboembolism. So take a proper family history, personal history, and rule out the predisposing factors to develop the same. And even if she doesn't have any predisposing factors, tell her about the red flag signs and use it for the minimum possible time, and also put her under contraception while she's using such drugs. The next thing is, when we treat a patient of PCO who has come to us for fertility treatment, then if she is a very she is a patient on the severe side of PCO and has a lot of follicles, it is very prudent to in the IUI cycles, I'm not talking of the IVF here, so in the IUI cycles where we intend to have the mono follicular growth, it makes sense to start the ovulation induction at a little later time, maybe on day 5, so that we get the monofollicular growth. Another very important feature which I would like to emphasize is that it is very important that a woman who's amenorrheic, not getting periods due to PCO, she should be given a withdrawal bleeding, and she should be treated so that she has at least 9 times of bleeding in 12 months period. This is important to prevent hyperplastic endometrium and prevent the risk of carcinoma in future, and many other reasons. This is very interesting that there are some patients of PCO in which you will see that the uterine size is a little smaller. It could be because of the chronic anovulation. So there is a role, if you select the patients carefully, there is a possibility that you can increase your rate of pregnancy by giving short a few months of HRT before you do the embryo transfer for this patient. It is very important that after we finish IVF and give a child to the patient gets a baby, after the fertility career is over and she's happy with the full family, after that it's important for 2 points especially to follow this patient and not just give up on her. So one is the psychological and body image related issues. So especially psychological, you can refer her to another doctor if you think that is a need. Otherwise, at least take the GAD-7 questionnaire, do the generalized anxiety disorder questionnaire, GAD-7, with her, and make sure that she is not having that aspect to be addressed left. The other very important thing is, please let this section of this group of patients know that there is a higher risk than general population to develop cancer of endometrium in future, and a very good way to prevent that is to use Mirena as the way of contraception after the family is completed. So these are some of the key features in PCO, and if I think of more points, I'll make another video. If you have any questions, you can write them in the comment section and I will take out time and answer them. And best wishes.